Dr. Bijal Shah from the Moffitt Cancer Center. I've been in practice now for about 13 years. I focus on the care of patients with aggressive lymphomas, in particular mantle cell lymphoma, as well as those with acute lymphoblastic leukemia. Today, we're going to be giving a high-level overview of the mantle cell lymphoma treatment landscape and how it's evolving. Mantle cell lymphoma is a rare and often aggressive form of non-Hodgkin lymphoma that arises from B cells. Mantle cell lymphoma has a wide clinical heterogeneity. Some will present in a more indolent fashion, some more aggressive, and some highly aggressive. And we have to think about that as we're adjudicating. Now, you take all of this incredible clinical heterogeneity, and then you add to it the rarity. It's only going to be around 5,000 cases a year in the US, about 6% total of the non-Hodgkin's lymphoma cases. So trying to learn from that, trying to grow from that, it's a challenge. I think for those of us that have been in the field for a while, we recognize the treatment landscape, not just for mantle cell lymphoma, but for all non-Hodgkin's lymphomas, a rapidly evolving space. We've seen the emergence of bispecific antibodies, targeted therapies like BTK inhibitors and BCL2 inhibitors rapidly come into our lymphoma treatment landscape space. And as a consequence, it's really informed how we think about folks at diagnosis, but also as we cycle through different therapies in the context of relapse. One thing I've been very excited about is how targeted therapy is really moving into the frontline setting, and we've seen this generalized approach of building on what we might otherwise get with chemotherapy alone. I think how we're going to be able to move forward in a way that's going to enrich our patients' lives, meaning prevent some of those toxicities, I hope, while also preserving that benefit. BTK is an integral part of the B-cell receptor pathway, and BCR signaling is central to the proliferation of mantle cell lymphoma. So BTK inhibitors have been a major advancement in the treatment of this disease. BTK inhibitors target the B-cell receptor and its downstream signaling cascade, which are critical for normal and malignant or mantle cell survival and proliferation. It's been observed that BTK inhibitors have shown diminishing efficacy with each subsequent line of treatment, so it's critical to explore different combinations and sequencing. One of the things that's really important to think about when you're seeing patients with mantle cell lymphoma is the strategy. We're not going to cure the majority of these patients, so we have to figure out how we're going to align the medicines we're giving so that we get the most mileage out of them. I consider various factors to help determine the patient's risk, prognosis, and appropriate treatment options. I start by emphasizing that it's incurable, and that we really need a strategy to think about how we're going to manage today and tomorrow. I then go on to talk about how I try to balance the intensity of the therapy I'm delivering with the cadence or aggressiveness of their disease. And so when we talk about Ki-67, when we talk about nodal bulk, when we talk about these factors, these are things that I'm thinking about. LDH would be another factor. But just trying to understand, what is their lymphoma doing? How is it behaving? And how do I need to react as a consequence? So as we pivot from newly diagnosed to relapsed mantle cell lymphoma, a lot of the same ideas are still in play. How aggressive is the disease? Where is it growing? How is it growing? These are all going to inform what we do. For someone who's got a localized relapse, it may be locally directed therapy. For someone with a systemic relapse, it may be systemically directed therapy. Many patients relapse after initial treatment. In one study of 455 patients with relapsed and refractory mantle cell, 39% of patients relapsed after first-line treatment, and among those, 50% relapsed within 2 years. Finding strategies to prevent relapse is critical. Trying to figure out how we avoid it, and this is where, again, incorporation of novel and targeted therapies in the frontline setting is going to be really important. There is generally poor patient attrition between lines of therapy. Notably, among patients aged 65 years and older, attrition due to death occurs in 23.8% of patients between first and second line therapy, in 27.5% of patients between second and third line therapy, and 29.9% of patients after third line therapy. This highlights the need for the most appropriate treatments to be used up front in aggressive lymphomas like mantle cell. Advancements, particularly in targeted therapies like BTK inhibitors, CAR T-cell therapies, anti-CD20 monoclonal antibodies, proteasome inhibitors, and BCL2 inhibitors, have helped expand the amount of treatment options available. Timing is everything with these patients, and choosing an appropriate first-line mantle cell treatment strategy is vital. I'm looking forward to continued research and further developments in this treatment landscape. Thank you for watching.